Hey, you guys, welcome back for our daily practice questions. As always, I like to start with my introduction and disclaimer before getting into the questions for today. So, for those of you who are familiar with me, hey, y'all. For those of you who are new here, welcome, welcome, welcome. I am Dr. Brittany Weinstock. I am a family nurse practitioner, and I am the founder and CEO of the Nursing Studio. I provide resources, courses, books, tools, and videos to assist nurses as well as nurse practitioners with success on boards as well as in practice. I have been doing this since 2015, assisting nurses as well as nurse practitioners internationally with exam success. We have a 99% pass rate on all of our comprehensive courses and a 100% pass rate on our one-on-one sessions. Now, I always like to get into this disclaimer because just a reminder, there's no absolutes in medicine, right? We treat on a patient by patient basis. And any of these questions I have designed based on the guidelines that are currently being tested on the ANTC as well as AAMP exam. Now, when I am doing videos and I'm teaching you on current guidelines and how we treat um, in practice, I will always say that so there's no confusion because there's some variances between current practice and what the exam may be testing on at this point. Okay, so with that being said, let's get into question number one for today. All right, you guys. Question number one states the nurse practitioner and NP student are reviewing the patient's PPD placement, and there's a noted induration of 15 millimeters. The patient was completing the PPD for work and denies any changes in weight, night sweats, cough, or having recent contact with someone diagnosed with TB. The nurse practitioner ordered a chest x ray and it is normal. Based on these findings, how should the nurse practitioner diagnose? Is it A, no diagnosis, the patient is healthy? B, latent TB? C, active TB? Or D, pneumonia? Take a moment and tell me what you have in the comments. All right, you guys, I always recommend reading the stem of the question first to ensure that you're even answering what they're asking you, right? This allows you to slow down and pay attention to what the question is really looking for. So here, the stem of the question states, based on these findings, how should the nurse practitioner diagnose? So if we're diagnosing something, we have to run it back and look at the assessment findings to see what we have going on, right? So the nurse practitioner and NP student are reviewing a PPD placement. There's a 15 millimeter in duration. The patient was completing this for work. They denied any weight loss, night sweats, cough, or recent contact with anybody with TB. Now, we know 15 millimeter in duration is a positive finding for TB for anyone, right? Because we know we look at our 5 millimeter, 10, and 15. 15 is healthy people and anybody, right? Now, the chest x ray is normal though. So, what does that mean? So here, this is where latent and active TB and things come into place. This is your best answer is B, latent TB. When we have latent tuberculosis, they will present with that positive PPD, but tuberculosis has been ruled out with the gold standard exams, such as your chest x ray, your sputum cultures, and things of that nature. The patient is not symptomatic. They haven't been in contact with anybody. So you want to kind of just watch this patient. These are the people who will get these updated chest x rays, but treatment is not warranted. They don't need to be like quarantined or anything because it is latent TB. There's nothing active. There's nothing that is contagious here. Now, if it was active, they would meet all of those the check boxes, right? Symptomatic, either been in contact, they had the PPD, the gold standard diagnostic exam, chest X-ray, and or sputum culture are positive, then that will be active TB. But here is latent phase, okay? All right, question number two states a patient presents to the office for follow up today, and she provides a log of glucose readings every morning and evening. Her morning readings are between 290 and 320, and her evening readings are between 40 and 50. She denies any complaints at this time, but was concerned at the fluctuation of her glucose levels. Upon examination, the nurse practitioner inquires about any changes in the patient's daily routine. She states that she is maintaining a low carb diet, taking her metformin daily, and exercising. She does mention that due to her work schedule changing, she is exercising around 7 p.m. at night. Based on these findings, what is the best recommendation by the nurse practitioner? Is it A, increase the metformin to 2 tablets in the morning? B, start the patient on Lantus for all day coverage? C, advise the patient to eat an evening snack and check blood glucose before and after exercising. Or D, advise the patient to eat an evening snack and increase metformin to 2 tablets in the morning. Take a moment and tell me what you got in the comments. All right, you guys. So, step the question states, based on these findings, what is the best recommendation by the nurse practitioner? All right. So, what is going on here? Patient comes in just for follow up. They have a log of their blood sugar levels, those glucose readings, right? In the morning, it's elevated 290, 320. In the evenings, 450, 40 to 50. So, it's in the lower range, right? Patient hasn't changed anything. She is continuing to have a low carb diet, taking her metformin every day and exercising, so doing all the right things. She does mention that her work schedule changed, so now she's exercising around 7 p.m. at night. So, what are our recommendations? So, when we're looking at this picture, we're trying to figure out, all right, we have early morning hyperglycemia, but evening hypoglycemia. This should paint the picture of the Samoji effect to you, right? Because Samoji effect, they have hypoglycemia in the evening. And as the body is compensating, there's a rebound effect causing that early morning hyperglycemia. So, really, the problem is the evening, the nighttime hypoglycemia. So, we want to treat that so that the morning blood sugar levels will normalize, right? So, would we A, increase metformin to 2 tablets in the morning? No, that's not treating our problem. That's trying to focus on those morning hyperglycemia. B, would you start the patient on Lantus for all day coverage? No, although at some point they may need all day coverage with a long acting insulin like Lantus, but right now that's not the problem that we're working on, right? C, advise the patient to eat an evening snack and check blood glucose before and after exercising. Let's hold that because that sounds pretty good. Or D, advise the patient to eat an evening snack and increase metformin to 2 tablets in the morning. Well, no, we don't want to do that because still we're not trying to focus on that morning hyperglycemia because we know that the source of the morning hyperglycemia is that nighttime hypoglycemia, right? Because with the Samoji effect, we have hypoglycemia at night, and that rebound effect causes the hyperglycemia in the morning. That's why when we're considering early morning hyperglycemia levels, you want to assess the morning and evening levels to rule out Samoji versus dawn phenomenon, right? So here, the best answer is C. With our diabetic patients who are exercising, we want you to exercise because it will aid in that insulin production and to help you to regulate your blood sugar levels and an overall A1C level, right? But we have to remind them and pay attention to these things because due to it working and doing all the right things, it can cause hypoglycemia. So no matter when they exercise, you really want to tell them to make sure that they are checking their blood sugar levels before they exercise. Typically, we like to say any physical activity, checking it before, but then also checking it again, maybe a few hours after they exercise, right? And making sure after that exercise, you're having a snack. So really here, we want to make sure that they're eating that evening snack after that late exercise that she's doing at 7 p.m., having her to check that blood sugar before she goes out and exercise and checking it a little bit after, but not just going straight to bed because that is causing that hypoglycemia in the evening and that early morning hyperglycemia. Okay, so C is your best answer. All right, and lastly, question number 3. The nurse practitioner and NP student are discussing sickle cell anemia. The NP student is inquiring if sickle cell is autosomal dominant or recessive. What is the best response by the nurse practitioner? A, neither sickle cell is simply the red blood cells having a sickle shape. B is autosomal dominant. C is autosomal recessive. Or D, there's an unknown origin. Take a moment to tell me what you got in the comments. All right, you guys. So, stem of the question states, what is the best response by the nurse practitioner? All right, so they're just simply talking about sickle cell and whether it is autosomal dominant or recessive. So, this is a knowledge-based question. So A says neither. Sickle cell is simply the red blood cells having a sickle shape, although it is where the red blood cells have a sickle shape or a crescent shape. That's not the answer. B, autosomal dominant, no. The answer is C, autosomal recessive. Sickle cell is autosomal recessive, right? Autosomal recessive. Think about it. Recessive has the extra S's in it, and sickle cell starts with an S. Autosomal recessive is sickle cell. Sickle cell is autosomal recessive. And that just simply means, with autosomal recessive, they need this to be passed from both parents to have it. Whereas if it was autosomal dominant, it would just need one parent to pass it. Sickle cell is autosomal recessive. Brittany's brilliance. The word recessive has two S's to remind you sickle cell, okay? S, sickle, autosomal recessive. All right, you guys, I hope you found this helpful. As always, be sure to like, comment, and subscribe and share with whomever you may think may find this beneficial as well. I am loving all of the participation. Thank you, thank you, thank you. The subscriptions help for this to get spread, for other people to see, and helps the channel to move forward. So I appreciate all of y'all as well. And if you need any of our resources or need any assistance from the Nursing Studio, please give us a call at 803-400-6864 or shoot us an email at thenursingstudio, the number one, at gmail.com. You can also shoot a text message to the number provided. Also, if you're looking for the review book, we have the ebook option and the paperback option. Both links are in the bio of this channel, along with our website link. We offer review courses that are self-paced. Our 5-week course, that link is also out. I'll put it in the description of this video as well, because it is open for enrollment. Get in while you have a chance. There's limited spaces available for our next one starting June the 10th. And if you want our one-on-one sessions, we do them based off either you can do it strictly just to focus on a weakness that you're having, or if you need a custom plan, which is the most common, we work based off of where you are. A lot of people, what they do, they've had an unsuccessful attempt, and we help you to see where that weakness is, assess where you are, design a structured study plan, and work alongside with you to bring you to a successful attempt. And we have a 100% pass rate with those one-on-one sessions. So just shoot us a email or give us a call or text to the number provided and see how we can assist you. But as always, make sure y'all meet me back here, y'all. Happy studying. Have a good day. Bye, y'all.